Hello anatomy colleagues, this is Dr. Alsup and we are going to get into the joints of the lower limb, which we're starting with the two largest ones. These will be the hip joint and the knee joint. And we will get through some of the things that we come to know about joints. So what are the bony parts? What type of joint is it? What types of movements are allowed? And of course, some of the clinical correlations and ligaments associated. So let's start with the hip joint. The hip, as you probably already knew, this is going to be the connection between the lower limb and the pelvic girdle. And recall that pelvic girdle is going to have an attachment to the vertebral column. So a bit more stability associated with the hip joint. And not only is there this stability, the stability is over a wide range of movements, which is really impressive in terms of its size. Next, but also next to the shoulder joint, is actually the most movable of all joints. So it's one of those oddities in the fact that there is quite a bit of movements that are allowed at this particular type of joint, but also a very stable joint. Usually when you have less stability, you have more mobility and vice versa. The hip joint is kind of one of the exceptions to the rule. This is going to be formed by the head of the femur, which is comparatively larger than what you had in the humerus. But what's really quite different is the depth of the acetabulum of the coxal bones. And recall that acetabulum is formed by the fusion of those three bony parts, the ilium, the ischium, and the pubis. Additionally, you'll also have a fibrocartilaginous lip, or a labrum, and you'll have two often that are going to be associated with this. This is a ball and socket joint after all, so you will have a labrum or a labra associated with this to allow for a better fit there. So you have these means of stability just kind of built into how it is built. So you have this really good fit between the bones. You have the labra that's going to allow for an even better fit. You have the strength of the joint capsule as well as the ligaments, some of the strongest, most robust ligaments in the body. And then you'll have attachments of muscles crossing the joint. So a very stable joint that's capable of all types of movements that can occur at a ball and socket joint. So that includes flexion and extension, abduction and adduction. And if you can do those four, what can you also do? Our good friend circumduction. So that's that complex movement of these four. And then since it is a ball and socket joint, it is also capable of medial and lateral rotation. Let's talk a little bit about the ligaments here. We will save our discussion of the specific muscles for another video, but you are going to have a complex of ligaments that will surround the articular capsule and provide a considerable amount of strength. And by far the largest and probably most important, definitely most important clinically, will be your iliofemoral ligament. And it tells you exactly where it attaches. It attaches from the ilium to the femur. It's going to be anterior and superior and very large. It will cover up the majority of the pubofemoral ligament, which is also anterior. And sometimes in some literature, you will see this referred to as the strongest ligament in the body. I don't know how true that claim is, but you certainly will see it, and it's certainly a very robust ligament, so it's on up there, if not the strongest. And it will play a very important role in terms of preventing hyperextension. So not allowing for the hip joint to extend well past anatomical position. That's why you can't hyperextend as much in the hip joint as, say, you can in the shoulder joint. You will have two other ligaments that are not as large. You'll have the pubofemoral ligament, which you can see a bit of here. It will actually extend a little bit deeper, but is completely covered by iliofemoral, the more superior you get. This will play an important role in terms of preventing over abduction or abduction. And then the weakest of the three will be the ischiofemoral on the posterior side of the joint. So this will will be seen here, and you can see that it is covered a little bit even by the iliofemoral, even on the posterior side. But it's really this iliofemoral that I want you to spend the majority of your time focusing on. Okay, moving to the knee joint, you will have, this is similar to what we had in the elbow joint region, where you have 3 joints that are going to be within one joint capsule. One of the bigger differences is that they're going to kind of work a bit more in unison than we had in that area. You will have 2 femorotibial articulations, so you'll have a medial and lateral. So basically where the medial condyle of the femur articulates with the medial condyle of the tibia, and the same thing on the lateral side. And you'll also have a femoropatellar articulation, so where the patellar surface of the femur is articulating with that largest sesamoid bone of the body, the patella. Okay, now 2 things I want to note before I move on. One thing that you do not see here, you see the femur, you see the tibia, you even see the patella, but you do not see that other leg bone associated with the knee joint. So the fibula does not play a direct role in terms of the knee joint. Now, some of the collateral ligaments will will attach to the fibula, but it is not directly articulating with any of these bones in this region to play a direct role in terms of the knee joint. And also importantly, this joint is relatively weak mechanically. And that has a lot to do with the fact that there's not a good fit between the bones. You have a very shallow tibial condyle with a fairly robust fibular condyle. So just mechanically weaker than some of the other joints of the body. Now the knee joint is a modified hinge joint, so there will be flexion and extension. That's going to be the primary movements allowed at the knee joint. And so you can see with flexion, instead of moving anteriorly like most flexions, when we're talking about at the knee joint, the flexion will bring that lower part of the limb to the more posterior side. Extension is moving back to anatomical position. Also importantly, some gliding and rotation can occur. And this happens when the knee is fully extended with the foot on the ground, so the foot is planted on the ground, the knee will kind of passively lock in place with a little bit of medial rotation. All right, so that locking will allow for muscles to relax briefly without making the knee joint too unstable. So that kind of will allow for a little bit of resting and not having to forcefully contract those muscles to allow for a full extension of the knee. And to unlock the knee, just a small amount of lateral rotation is needed. So when I say there's rotation, I mean very, very slight rotation, just to allow for a little bit of a better fit in terms of the articular surfaces there. Okay, let's talk ligaments, and there are a lot of ligaments when we're talking about the knee joint, and probably the largest, and some would argue the most important, will be the patellar ligament. It's actually the distal part of the quadriceps femoris tendon. So you can see at this point it's going to be the tendon, and then from the part from the patella to the tibial tuberosity, which would be just deep to this, since it's connecting bone to bone, it is considered a ligament. So this would be the patellar ligament. This would still be the tendon. As I mentioned again, it will attach on the patella to the tibial tuberosity, or the anterior superior part of the tibia. And this is with a capital T-H-E, the anterior ligament of the knee. And you actually don't have a complete articular capsule, so the anterior portion of the articular capsule of the knee is incomplete. And really, this patellar ligament with some of the retinacula from the tendon of the quadriceps. So this kind of complex right here really plays a role in terms of serving that function of the anterior portion of the articular capsule of the knee. You have two collateral ligaments, and they will tell you exactly where they are going to attach. You will have the fibular, or sometimes referred to as the lateral collateral ligament, so from the fibula up to the femur. And this particular collateral ligament is going to be rope-like. It's going to be a very strong ligament. You'll actually have a tendon that will run just deep to this ligament, the popliteus muscle, and it will pass deep to it, so it is completely separated from the capsule. The tibial collateral ligament is going to be considerably weaker than the FCL, and sometimes you hear the tibial collateral ligament referred to as the medial collateral ligament. And as I mentioned, this is going to be the weaker of the two collateral ligaments, and also very importantly, it is going to be attached to the medial meniscus. And we'll talk about that in just a moment, but it's going to have an attachment to the medial meniscus. So let's talk a little bit about those menisci. Recall, menisci are going to be fibrocartilaginous, kind of incomplete discs that are located on articular surfaces. And in this case, these are going to be located on the articular surfaces of the tibia. And recall, those tibial condyles are very shallow, so these menisci are going to kind of allow for a little bit of a better fit. It also is going to play an important role in terms of shock absorption. And the medial meniscus is going to have, it's going to be firmly adhered to the deep surface of that tibial collateral ligament on that side. So that implication of such a close connection between those two structures means that if one of those structures gets injured, it's very likely that the other one will as well. So that attachment between these two structures is key. The lateral meniscus is nearly circular, so you almost have a complete circle, but not quite, and it tends to be smaller. Usually it's going to be less frequently damaged than the medial meniscus. And last but not least are the two cruciate ligaments, and you can see they form this almost crisscross shape within the joint region. So these are going to be intracapsular, or within the capsule region. The anterior cruciate ligament is, as its name would suggest, the more anterior of the two cruciate ligaments. And it's also going to be the weaker of the two cruciate ligaments. So if a cruciate ligament is damaged, it is almost always the ACL. And it also, in certain resources, you'll see it may have an attachment to the medial meniscus as well. So oftentimes you'll have that complex of those three structures injured, and we'll talk about that in a bit more detail in a moment. But really, this ACL plays an important role in terms of preventing anterior displacement of the tibia on the femur. So does that tibia move too far forward? That could indicate that there is some type of damage to the ACL. And vice versa, if you see too far of posterior displacement of the femur on the tibia, that could be indicative of an ACL injury. The posterior cruciate ligament is kind of doing the opposite of the ACL, but a little bit better in terms of the fact that it is less frequently damaged. It is a bit stronger of a ligament. It is very important in terms of stabilizing the femur when walking downhill or, say, walking downstairs. It's going to play an important role there. So, whereas the ACL would prevent anterior displacement on the tibia, of the tibia on the femur, the PCL will prevent posterior displacement of the tibia on the femur. And so again, let's kind of return to some of the clinical correlations that are associated with the knee joint. And recall that we talked about this really close connection between the TCL, or the tibial collateral ligament, and the medial meniscus, saying that they are very often injured together. And also, oftentimes added to that mix is the ACL. And so if you have an ACL, TCL, and a medial meniscus injury, this is referred to as the unhappy triad. And it is ever so unhappy because you can have a complete rupture or a tear of these structures. It typically happens with a blow to the lateral side of the knee, which is kind of counterintuitive because these are more medial structures, particularly the tibial collateral ligament, but that force kind of moves through that region causing this. Also, excessive twisting can play a role, or excessive rotation can play a role in terms of damaging these three structures, particularly with twisting. That ACL is often considered. Now, can these structures be damaged individually? They absolutely can. You can have just an ACL injury, or you can have just a TCL injury, but due to their close proximity and their relative weakness, it is not uncommon to have 2 or 3 of these structures injured at the same time. All right, excellent. So that is the hip and the knee joint, some of its highlights. So let's go over this question together. So the anterior portion of the articular capsule is incomplete. Which ligament functions as the majority protection of the anterior knee? Is it the ACL, the fibular or lateral collateral ligament, the patellar ligament, the posterior cruciate ligament, or the tibial/medial collateral ligament? So let's think about the stem here. So this first sentence is just a statement. This is true. The anterior portion of the articular capsule is incomplete. That's just a statement, but it kind of is telling you that we need to be focusing on this anterior portion. So which ligament is going to kind of play the role of that articular capsule on the anterior knee? So we can go through these ligaments and see, do these make sense in terms of providing protection to the anterior knee? The anterior cruciate ligament has anterior right there in the name, so we might want to keep that one around to consider more. Fibular or lateral collateral ligament is a collateral ligament, so those collateral ligaments are always going to be on the sides. So not so much in terms of an anterior protection, so we're not going to go with this one. Patellar ligament, where's that located? Well, remember, the patella is very anterior. The patellar ligament is between the patella and the tibial tuberosity, so this is in the anterior portion. Posterior cruciate ligament, not so much. It's intra-articular, it's posterior, so we're not going with that one. And then here's another collateral ligament, so this is on the opposite side, but still not so much anterior. So another part of the stem right here is saying the majority protection. So anterior cruciate ligament is going to be inside the capsule. So it was never really going to play that big of a role in terms of kind of taking over where the anterior portion of the capsule would be. And also it's not a particularly protective ligament either. So we're not going to go with that one. I think the patellar ligament, if we return back to that image, is really going to play an important role in addition to the tendon, which is really, this is just an extension of that, and the retinacula. So basically this tendinous complex with the ligament being an important part of it is going to play a role in terms of providing that anterior protection to the knee. It is the anterior protection. All right, excellent. I love, love, love the hip and the knee joint. They are all so complex and so different in terms of both movements and protection, so they're interesting to talk about. But as you review these and as you try to get a handle on some of these ligaments, please make sure to reach out with any questions that you may have. And I thank you for your time and attention, and we will move on to the ankle joint in the next video. Thank you.